Welcome everybody to the webinar on ES and ELCP from basic to the advanced. I'm really thankful to all of you for joining here. I'm really thankful to my co-host, Dr. Saad Niaz, who has agreed to being a director of this webinar series. We're going to run about 40 sessions of ES and ELCP webinars in the coming days. And this is going to be done on every Sunday at 6 in the evening, Pakistan Standard Time. I'm really thankful to David Carr, who is a very experienced veteran in the Rcp and advanced endoscopy. And he kindly consented to give this opening lecture on the learning curves in ERCP and the equipment required. Why did I choose this topic? For the simple reason that if I look back in my own training time, when I started my career way back in 86, 87, I recall the days when we used to stand in the fluoroscopy room without any safety equipment. And similarly, there was not much of safety equipment available for the patient either. So to highlight the safety aspects of the patient and the endoscopist at the same time to conduct a proper ERCP, what is really required other than David Carlo can highlight. And then the learning curves required to do ERCP, and then the advanced thing that we really need to do in the ERCP. ERCP is not just simple putting in a cannula or a guide wire into the CVD and then thinking that our job is done. Doing it in a competent fashion, for example, taking out the stone, small stone, large stone, and taking out the obstruction while the patient is suffering from cholangitis, that always requires a careful consideration. Similarly, when there's a stricture in the distal CVD or there's a stricture in the proximal CVD, analyzing the stricture, delivering the therapy in a proper way, all these things require a proper consideration. And for that, obviously, you need expertise, you need learning, and each and every intervention that we do in the humans, they require some degree of abstract thinking. And I've requested David Carlo to give us a highlight on this issue. COVID has given us a new challenge. We, the old timers, we are very comfortable with one-on-one teaching. And let me tell you that these online sessions are not alternative to the true mentorship we have while sitting in front of the mentor or working directly under the close supervision of mentor. And similarly, when you're working in a proper training program, but to give you a flavor and to expose all of you to the experts of the word, we have organized this webinar series, and I'm sure this is going to be beneficial to you. I'm really thankful to the Administration of Pakistan Society of Gastroenterology, Asian Endoscopic Ultrasound Group, and then the academic bodies like College of Physician Surgeons, uh, Dow University Hospital Sciences, King Edward Medical University, and University of Health Sciences for allowing us to use their forums so that the message may go wide. And similarly, the endorsement may be given to all the students who are enrolled in their training programs. With these, I shall not stand between you and David Carlo, and I shall request Saad to give you words and then introduce Sir David Carlo so that he may give the presentation. Saad?
Thank you, Riaz. Without any further ado, may I request Professor David Carlock, who needs no introduction. He's a master in this field. He's one of the guys when it comes to ERCP, and we have had some experience of seeing him live in Pakistan. He has been a friend of Pakistan, so we really appreciate you taking time out, David, and we look forward to hearing from you. Over to you, David.
Thank you, Saad, and thank you, Yes, for inviting me. Thank you to everybody that's listening, and greetings to Pakistan from New York. It's a Sunday morning here. I'm sitting at home, so it's very comfortable. Thank you. We've all got used to these Zoom meetings, which have changed the way we communicate and educate. But as you rightly say, it does not replace the in-person training that still takes place in a slightly different way from how it used to before COVID. We are much more protected, I will come to that in a moment, than we were before, but the principles of teaching, of course, have not changed. I congratulate you on this very ambitious project of 40 weeks of teaching using a very structured format. I saw the program and I realize I am the first one. So I am going to try and set the scene for you to tell you what's coming, what you should focus on, and fill in a few, and I'm happy to answer any questions at the end. Hopefully we will have plenty of time for that. Thank you to the Society for inviting me to give this topic, which of course is now a very large topic. And I want to make sure I convey to you that even though I'm going to focus on certain aspects of equipment and learning, it's meaningless without knowing everything else that surrounds ERCP, which has become a very large specialty. And that's why you have so many topics on your series. So I wish I had time to listen to all of them, but maybe we'll listen to some. So here I am at the beginning of this series to set the scene for you. Now, as you heard, we are good friends of many of you in Pakistan, and this was the last time we visited Giyas in 2018. And of course, the world has changed considerably since then. Sarah's there, she's somewhere behind me right now in the home, so you can't see her. But I have visited many parts of your country, as you know, and also have great friends in Islamabad and Rawalpindi. And many of you may not know that I have family connections with that part of Pakistan in the 1930s and 40s, because my grandfather, my father's father, was Postmaster General of India during the British time, and my father grew up in India and often visited Pindi, that part of the country. And so when I showed him this picture from 2006, was one of my first visits, he said, "I know where that is." So he was very happy. Of course, he's no longer with us. So a long tradition with Pakistan, which I'm very proud of. And I'm most proud of this. I have my own ERCP room at the Holy Family Hospital in Pindi. So you don't have to go there to be trained, but it's one place that you can be trained. And also I was very honored by this event that year, 2018, when they put up these enormous posters. We don't do this sort of thing here. It's a shame, but I was very impressed with these pictures, and I was honored to present many topics and live demonstrations at that time. Now let's go back a long time. Why are we so fixated on the bile duct and the pancreas? Well, because of course it's important, because many things can make patients sick. But it was known for a long time that bile was an important substance. Hippocrates, if you can see when he was alive, he knew that bile was important. Didn't quite understand everything, but there was this whole idea of the humors, earth, fire, air, water, that he combined into his view of medicine. And you see two of the elements are bile, yellow bile and black bile. And it's interesting that the black bile, if you translate that into a word, is the word melancholy. Melancholy comes from the word black bile. So if you're sad, it means your black bile is higher than it should be. That was the thinking many centuries ago. So it's been in the idea of medicine for a very long time, even without knowing what it was. And the pancreas was known to be an organ a long time ago. Herophilus was probably the first anatomist to recognize that there were organs that did different things. Didn't know what they were, didn't know what to call them. And in fact, the pancreas didn't get a name until the first century, when this guy Rufus of Ephesus decided to call it the pancreas because it looked like flesh. Pancreas means all flesh. Again, didn't have any idea of what the function was. It was the famous anatomist Andreas Vesalius in the 16th century that really discovered the gallbladder and realized that it contained bile. Again, didn't know what it did, but he documented it. And then I'm showing you these words because we still use their names. Versung, as in Versung's duct, described the main pancreatic duct in the 1600s. There was one of his drawings, which is fairly accurate, not perfect, but pretty good. And so we call the main pancreatic duct the duct of Versung. And Santorini described many things, but the one that bears his name is what we also call the accessory duct. That's the duct from the main duct to the minor papilla, and is also known as the duct of Santorini. And many of these anatomists, if you ever go to Italy, they were nearly all Italian or German, were dissecting bodies and demonstrating anatomy at a time when it was not legal. And you see some of the anatomical theaters, which are very interesting places to visit, were done completely behind closed doors so that they didn't get caught by the religious leaders at the time. And then Abraham Varter in 1720 described what we call the Ampullary Varter, or the major papilla, which is not quite the same thing, but we can discuss that at the end. And we still use his name today. So the Rcp and Eus. I know I'm not specifically supposed to talk about Eus, but today you'll see from some of the pictures I'm going to show you that these two things are inseparable. They have become part of our management of patients with pancreatic and biliary disease. And the other thing that has changed, certainly in the last 2 or 3 decades, is that it's become both procedures have become therapeutic. So you should think of the Rcp and the Eus as imaging integrated with therapy. It's not imaging alone, which is how both of these procedures started. It's integrated with what we can do to help our patients. And one big change that occurred that I remember very well in the early 1990s for us was the introduction of MRCP, which really took away the need for diagnostic ERCP. So if you have access to an MRI machine today that will produce an MRCP image, like you see on these two pictures, the need for pure diagnostic ERCP is now no longer necessary, which is good because many of the complications did occur from just pure diagnostic procedures. So that's another thing that changed our world. So where are we today? We're in the middle of a huge array of therapeutic procedures that encompass all of these things, and you'll hear all about this during the next 40 weeks. I'm not going to go into too much detail about each of them, take too much time, but just to give you an idea that we now treat many, many conditions using the same types of scopes that we've used for the last few decades. And the US is the same. It's become much more therapeutic than it was at the beginning. So just as one example, I'm going to show you a procedure that is not something we do every day, but a removal of an ampullary adenoma has now principally become an endoscopic procedure rather than a surgical procedure. And this is just one example. It just happens to have some nice music to accompany it. Here we go. show you that, apart from the music. Because that single procedure, which took about 2 hours to do, and I condensed it into a couple of minutes, encompassed all of the techniques that you need to learn. You know, cannulation, removal of a tumor, stenting, guide wires, and so on. And that's a high definition image, which is again what we're used to seeing now with modern endoscopes. So all that one procedure included many of the techniques that you're going to learn during your training. So if I think about what we have to consider in learning ERCP, it's many different things, and that's what this teaching course is all about. I'm going to focus on the equipment side of things and to some extent on training. But as I said at the beginning, those things are meaningless unless you have some background of many of the other aspects which you will learn during the next few weeks. And I like to show this picture because it brings two things together that you wouldn't normally expect. If you think about how you get good at ERCP, you learn many things. Of course, you learn how to cannulate, you learn how to use fluoroscopy, you have to understand anatomy, pathology, of course, how to diagnose and treat conditions. And then look at the last thing, complications. We always like to forget complications when we don't want them to happen. But those two things come together. If you had a bad indication for the procedure and your patient got a complication, then you're in bad trouble. Now, in this country, we always think of medical legal implications, but just for the patient's well-being, if you do not have a good indication for what you're doing, and the patient has a complication that is life-threatening, of course, you will regret it, and that should not be the case. So always think of why you're doing everything that you do, and of course, do it right, and that's what this training is all about, but also try and avoid complications. And there are many ways that we have learned how to do that. So as I said just now, ERCP and EUS go hand in hand. We don't really think of them as separate procedures now for pancreatic or biliary diseases, because whether we're diagnosing, removing, resecting, relieving obstruction, or preventing problems, we use both of them together, particularly for relieving problems that we cannot necessarily do entirely by ERCP. So what is the purpose of ERCP? As you well know, it's giving us access to the two systems that you see here. The biliary system from the ampulla right up to the liver, and the pancreatic ductal system. And in most people, of course, they come together at the major papilla. There are exceptions to this, and you will learn about the variations. But the way that we access it, of course, is to provide and place a side viewing endoscope. It's a side viewing endoscope for a very good reason, because if you don't look sideways when you're in the second part of the duodenum, you do not get to see the papilla, which is the point of access to the system for most patients if they've not had surgery. And the other fundamental aspect of what we do is dependent on the placement of guide wires here into the pancreas, here into the bile duct, and sometimes we do both at the same time. So there are many aspects of placing, accessing, and performing procedures within the two ductal systems that has become very basic to therapeutic ERCP. Just as an example, I'll show you one of our patients from a while ago. This is a patient you see having an ERCP with a guide wire already placed in the pancreatic duct. And you can see the pancreatic duct here is dilated because there's a tumor sitting right here. That bile duct has also been cannulated and was also obstructed. So this is a patient with double obstruction and requires both sampling of both strictures, which we did, and then stenting of both. And so you end up in this patient with stents in both ducts. So the ability to place guide wires has become fundamental to how we perform therapeutic ERCP. And here I'm immediately showing you now an EUS patient because ERCP in this particular individual failed. We know this patient had a stone from imaging, but we could not get access to the bile duct. You can see the papilla here is on the edge of the duodenal diverticulum. So EUS has given us guide wires by directly puncturing the bile duct and passing a guide wire down into the duodenum. You see it exiting the papilla here. It's picked up by the duodenoscope, and then we use it for whatever therapy, in this case, balloon dilation of the papilla and removal of the stone. So here, EUS ERCP is done as a combined procedure at the same session. We haven't had to bring the patient back. We haven't needed to go to radiology outside of the ERCP. Here's another one, just to show you a few examples, because I'm not going to deal with the US anymore after this. Here's a patient with malignant obstruction of the bile duct we could not get access to because the duodenum was obstructed by cancer. Here, EUS access with the needle into the dilated bile duct and direct placement of a metallic stent directly into the bile duct. So this is antegrade stenting. Now, there are many procedures to solve the problem of biliary obstruction that we cannot solve by ERCP alone. And again, show you a few examples. You can see much more of this in the lectures that will follow over the next few weeks. We can access a peripheral duct through the stomach directly into the usually the left system to place a guide wire, as I showed you. And stents can be placed from below if that gives us access, or they can be placed from above, IEUS. You can also place directly a stent into the from the stomach into the liver, hepatic gastrostomy. We can access the bile ducts, as I just showed you, for rendezvous access and stent or stone management. We can place stents directly into the bile duct via a cholangitis duodenoscope, endoscopically. Different stents will allow us to do this. And then finally, we can access the gallbladder, sometimes for treating cholecystitis, sometimes for other reasons. And we can place stents in there too. We can do the same for the pancreas. When it's obstructed like this patient, we could not get access through the normal channel, so we access the dilated pancreatic duct from the stomach by EUS, place a guide wire, and that allowed us to do the necessary therapy. So a lot of this comes down to understanding anatomy, and as soon as I show this slide with the word anatomy on it, everybody goes to sleep because they don't want to learn anatomy. That's something you learned a long time ago and you forgot. Well, unfortunately, you've got to remember it now because it's very important for what we do. So there are many, many beautiful anatomical descriptions of the things that we access. This is from the 1930s. An American anatomist looked at all the very detailed musculature around the papilla. Unfortunately, it doesn't really help us very much because this is what we see when we're looking at the very normal flat papilla. And what you're going to learn about cannulation, which is the fundamental first step in the RCP, is that you have to understand what it is you're looking at and how to overcome that part of the procedure. And the reason that it might be difficult is that there's a segment of bile duct within the wall of the duodenum, this section here, that you will learn called the intramural bile duct, which is the part that gets in your way. You've got to overcome this, this segment of the duct, and it's always there. Maybe different lengths and different shapes, but it's always there. And many of the techniques we use to cannulate overcome this part of the bile duct to gain access. Now, anatomy of the biliary tree is important. We call it the biliary tree because it looks like a tree, and here is one that does look like the bile ducts. But you have to understand what you're looking at, what parts are called, how many segments there are in the liver, and the fact that the lower bile duct traverses the head of the pancreas. A lot of people forget that this part of the bile duct is very different from the proximal part. The cystic duct may enter many different places, and there are certainly variations in anatomy that can occur that are normal and expected, and you have to understand what they are. CT scanning is now so good, almost as good as MRI for many things, that you can see when it's obstructed like this. This is the bile duct right here. You can see it very clearly on this coronal view. But remember also that different parts of the bile duct are either retroperitoneal or intraperitoneal. And that's important because of the complications that occur, and I'll come to that in a moment, particularly at the lower end where we perform sphincterotomy. So it's important to understand that on an MRI like this, or an MRCP, you can see many things. You can see the duct here of the pancreas, which is normal. You can see a normal bile duct. You can see the gallbladder. You can see water in the duodenum. Remember this, the MRCP image really just images water. Here's the stomach. So you have a lot of information on one picture that tells you many things about the anatomy of the ducts that you're interested in and the relationship to other structures that may be close by, which of course are important. Now, aberrant anatomy is often thought of as a Western problem because we see all these funny ducts, but I can tell you that they happen in Pakistan too, because this was a live course in Rawalpindi, and I can just happen to take this picture, or somebody did, showing a patient with two right hepatic ducts. You see here, if I just take the arrow off again. There's the left duct. There are 2 right hepatic ducts. There are 4 zones, 4 segments in the right lobe. Each one has two segments have 1 duct filling them. So 6 and 7 and 5 and 8 have, in this particular patient, have separate ducts. And that's really not uncommon. And sometimes the gallbladder is attached to this one, which is very important for our surgeons to understand so that they don't injure it. But it's important for us too, because if you do an ERCP on a patient after a complicated cholecystectomy and you only see 1 of these ducts, then you know that something's not right. And you have to be aware that these ductal aberrations can occur. The pancreas is a very interesting organ because it does not have a capsule. It just sits at the back of the peritoneum. It's an entirely retroperitoneal structure. And that's important because when things go wrong with the pancreas, particularly pancreatitis, the fluid is dumped into the retroperitoneum. And that retroperitoneum can go all the way up into the chest and all the way down into the pelvis. So it's a very different sort of structure from something like the stomach or the intestine that is intraperitoneal. You will have to learn about complications. I'm not going to spend too much time on this because I think somebody's dealing with that later. But these are the ones that we are very familiar with that we would like not to happen. We've learned how to reduce the risk of pancreatitis greatly, not to 0, but much less than it was. We know how to deal with bleeding, perforations. I'm going to show you a couple of examples. And of course, drainage is the treatment for cholangitis. But acute pancreatitis still occurs. Here's a patient with a lot of fluid around the pancreas after ERCP. It's a mistake to think that these patients all recover with very little treatment, and that's not true. There are still some patients with severe pancreatitis after ERCP, and we have to be aware of that. Post-sphincterotomy bleeding, again, doesn't happen too often now, but we have many techniques available to us for hemostasis, and you're well aware of those. Perforations can also occur. This is a perforation of the duodenum. So this is a lateral perforation caused by the endoscope itself. You can see the size. I don't know if you can see my cursor here, but the size of this perforation is exactly the same size as the tip of the endoscope. It looks like this. It's into the periduodenal fat, so it's not a free perforation. Patient's stable, you have time to close it, and now we're able to do that with many of the devices that we have available to us, such as hemostatic clips. And that patient went home. This is the type of perforation that we see more commonly at the sphincterotomy site. So you see here a patient with a papilla, and there's a diverticulum just north of it here. And the sphincterotomy occurred because of this large stone that had to be removed. And everything went well until here. What you see here is the outline of the right kidney, which tells you that there is gas around the kidney. Otherwise, you would not be able to see it like this. So you know that's a perforation. It's retroperitoneal. We use carbon dioxide now routinely. If I forget to mention it again, we use it routinely for all endoscopies. But if you had to choose one area to use it, do it in the ERCP room because it reduces your risk of bad complications in place of air. In this particular patient, we drained the bile duct, everything healed, and we came back another time to deal with it. And if you do a CT scan, this is what you see. You'll see air in the retroperitoneum. Everybody gets very scared about this. And most of these patients actually will heal with conservative treatment and antibiotics that do not need surgery. And the last thing is cholangitis. Of course, if a patient comes to you with cholangitis, you're treating it. But you can cause cholangitis by infecting an obstructed system. And the place that we used to do this most commonly decades ago is the hilar obstruction patient here, where we accessed the biliary tree and we couldn't drain it adequately and patients got infected. We don't do that anymore. We don't access the biliary tree with any device other than the guide wire at the beginning. Once you have guide wire access, you can do really anything you need. Particularly drainage, so that has changed the way we manage these patients. So now let's turn to the endoscopes themselves. The history of endoscopy, endoscope production is very interesting. It goes back a long time. These are some ancient endoscopes that we no longer use. Things changed in the late 1800s with Thomas Edison's invention of the electric light bulb, because then illumination could be made electrically. They were still rigid endoscopes at that time until Schindler came along in the 1930s and produced a semi-flexible endoscope, and I have one of these in my office. It's really not very flexible, so, but it was better than the rigid scopes that happened before. And then in the 1940s, we saw the development of the gastro camera. And that's when I was born, around then. So here I am in 1949. And then in the 50s, we saw the development of fiber optics, thanks to Sir Harold Hopkins and his partners. And Basil Hershowitz produced the very first flexible endoscope in the 1950s. And that led the way to everything that's happened since. The fiber scopes were produced by the millionth in the 1960s. And here is Hiromi Shinya in my old hospital in New York in 1967 doing the first colonoscopy and polypectomy. Some other people were around at that time too. So that was the fiber optic era. And then in the 80s, things changed again to the video endoscopes that we have today. And that became possible to produce a video duodenoscope, which is of course what we use now, and the echo endoscope for US. So therapeutics became possible with the birth of sphincterotomy. And Damling and Klassen in Germany in 1973, and Keiichi Kawai in Kyoto, Japan, also in the same year, produced the first therapeutic maneuver, sphincterotomy. They did it different ways, but same intention. So this is Germany, this is Kawai, this is Klassen and Kawai talking to each other. And many years later, both sadly passed on now. In fact, Professor Klassen just died recently. But 1973 was the turning point, 47 years ago, when therapy became possible. And my career started just a little bit after that, 1975, in the UK. And I started doing Rcp at that time. We did a lot of strange things that we wouldn't do today, like not wearing gloves. Can you imagine? But that's what we did. These were fiber optic instruments. We didn't protect ourselves very well either, and nor did we have a fully insulated endoscope. So every time I stepped on the pedal to do a sphincterotomy, I would get a shock on my nose where the scope was touching my face, and we figured out how to stop that after a few because it hurt. And we also learned how to do what you're learning to do now, for those of you that are just starting, and that's how to position the endoscope. At the beginning, we didn't understand how straightening the endoscope would make such a big difference. You can see all of these early pictures are terrible. If any of my fellows did this now, I would say that they don't know what they're doing. But we did eventually figure out that by straightening the endoscope, everything came into position and everything became so much easier. So we did that after a while. We had no tools to begin with. We had to borrow them or make them ourselves. These were some handmade sphincterotomes. Now you have, of course, many available commercially. And extraction devices we borrowed from urologists and made them longer. So these were the beginnings in the 1970s. And in the 80s, the scopes became video. And this allowed us to transmit the images electronically, just as we do today. And that has continued. And this gives me, allows me to make one very important statement, and that's the teamwork aspect of this. I'm not really dealing with what the technicians and the nurses do with us in the ERCP room, but ERCP is a team sport, right? You cannot do it by yourself. If you're on your own, you really don't have enough hands. You don't have enough ability to do all the things that you need to do. So when you start training, you should be training not only yourself and your colleagues, but everybody around you. That's the technician or nurse or both, and a radiology technician if there is one, because all of you have to work together to achieve the goal of whatever it is you're treating. So teamwork is one of those fundamental things that has to take place. My own career changed when I moved from the UK to the US in 1989 to Brigham and Women's Hospital in Boston. And then I moved to New York in 2010, so 10 years ago. And then 2017, just 3.5 years ago, I moved uptown to where I am now, and that's Cornell, New York Presbyterian Hospital, which sits here on the Upper East Side. And I was very fortunate to be recruited to open the new building today that we have a whole floor of endoscopy rooms, which you see here. You'll see them again in a moment, which I was asked to equip. So I got a lot of experience from buying equipment, which I think is helpful for me to tell you. So let's go back to that original list. Now I'm going to go to some of the equipment aspects, and finally end up the trade. So what are the features of a duodenoscope? There are many manufacturers. We have 3, you may have more, because we don't have access to other foreign manufacturers that don't import into the US. But they all basically have the same features, right? They are flexible endoscopes. They have the same control handle, which you're used to for other endoscopes. But instead of looking forwards, they look sideways. Here's the lens system. Now here's the biopsy channel, which has another feature, and that's the elevator. This elevator is absolutely fundamental to what we do, because it allows you to manipulate all of the tools that we use during the RCP. One thing that has just changed in the last year is the fact that this tip of this scope has been redesigned because of transmission of infection, which is a whole different topic, nothing to do with COVID. But this is now has been changed to have a semi-disposable feature on it that you can take off and clean. You can throw the cap away and you can have access to the channel that needs to be cleaned. So this is an Olympus 180 duodenoscope. You may have the 200 system, I think, in Pakistan. This is the Pentax version. You can see it's very similar. The controls are very familiar to you. The additional part is this elevator lever at the back here. This is Fujifilm's duodenoscope. Also, same basic design, same features. And then you would think that would be it. But now we have a whole new world of the disposable endoscope, which I would never have believed that would even be possible. But Boston Scientific just got approved last year for this first disposable duodenoscope. It does all the same things. You can see it looks very similar. It's even black like all the other ones, except for the umbilical cord. It has its own light source box. It has same channel, elevator, lens system. Produces a really very good image. I was happy to be the first person to use one of these during a live course in January this year. But this is what you do with it afterwards.
Okay, we're doing video of you.
Yeah.
Okay.
Ready?
Yeah.
You throw it away.
Okay, that's history. Okay.
History, yeah.
Can you believe that we would throw an endoscope away? It doesn't feel right, but it works pretty well. And the whole idea, of course, is that you don't have to clean it because it's disposable. There is now another company that's come to us from Europe, Ambu, that's also been making disposable bronchoscopes, now is making disposable GI endoscopes, and this is their duodenoscope, which I have not used, but will be with us shortly. So that's all changed. But the principle of how you use it and what you use it for, of course, has not changed. We're going to learn a number of maneuvers that you need to be aware of, how you move the endoscope. There are actually 14 different things you can do to an endoscope to get it where you want it to be and to do various things. The control knobs, the rotation, the elevator, and the accessories. So many things you can do that you will learn that are part of the ERCP maneuverability. But you do need other endoscopes too, because we have many patients with altered surgical anatomy. You need to have forward viewing scopes that are not designed for ERCP that you end up using for this purpose, including the single and double balloon enteroscopes, which we sort of love to hate. We have to use them when it's necessary, if we can't do it by EUS or any other means, and sometimes these procedures take a long time. These are the situations where you have to think about this. Partial gastrectomy, you can see it's a long way to the papilla. Pancreatic surgery, there is no papilla, but there's a biliary anastomosis that you have to reach. The patagojejunostomy, this is the one that really is the worst because the stomach is intact. It's a long way to that jejunostomy down here, and then you have to go back up to the biliary anastomosis. So you sometimes have to use a colonoscope or double balloon enteroscope. And this is the one that you probably won't see very much of in Pakistan. I don't know how much through gastric bypass patients you have, but here you have to decide which way to go. And you reach the jejunostomy, and then you find your way up to the papilla with a scope that wasn't designed for cannulation. And you're lucky if the channel lines up with the papilla, as it usually doesn't, but you make it do that if you can. And then you do the therapy, which is usually for stone disease, and balloons are important for that. So that's all I'm going to say about the scopes. You can certainly ask me questions at the end. Another important consideration if you let's say you're starting a new ERCP facility is where you put the equipment. So the design of the room is very important. There are many ways to do this, but this is a very common one. This is the one we use. Here's the patient on the table. There should be space for anesthesia or whoever's giving sedation to stand at the head of the bed. This is your territory right here, and you have to be surrounded by your equipment, which is usually behind you. Your assistant must be available to your right, like this, and then they have access to a preparation table, which has all the accessory equipment on it that you need. Anesthesia needs its own equipment behind them, and then this is the fluoroscopy machine, and then it's a display screen. So that's a very common setup. I would point out that depending on the patient's position, this viewing screen that's here shown in front of the physician or the endoscopist should be movable. Sometimes it needs to be over here. So this is one of our new rooms. This is a standard room for all endoscopy, but you see here a C-arm that can be brought in to allow ERCP to be done, but endoscope systems are over here on the right. There's electrosurgery. This is anesthesia. Display screens are all around the room, and this is the C-arm. So this is a variable room. This is one of our standard advanced rooms where you see the patient here supine under anesthesia. Here's my colleague, Green Shariah, doing a procedure. Endoscope setup is behind her. Here's electrosurgery. These are assistants at the back here. This is a visiting physician. Here's the screen, which is on a movable suspension system, can be placed wherever we want it. So flexibility is also important, but you have to understand how the room is going to be used. This is one of our older rooms where we spent a lot of time. This is a C-arm, but it's a high quality C-arm like the angiographers use. The screen is over here, it's also over here. You can see how with the patient supine, you're often facing away from the patient, which is normal. And so the screens need to be over here instead of on this side of the table. And so these two screens are suspended next to each other, and that's also important. This is Cedars-Sinai Hospital in Los Angeles, where we do a course every year. Here you can see the screens are one above the other and situated across from the patient who's lying in front of the team here. So think about the room. I'm going to say a few words. I know I'm going to run out of time, but I'm going to say a few words about electrosurgery because we use it so frequently in ERCP. It's been around since the 1920s. People like Christian Irby in Germany, and then William Bovey and Harvey Cushing in the United States produced machines that would allow us to use electrosurgical tools. Today, of course, it's all changed. You buy a generator that fits your needs for endoscopy, and there are many, many manufacturers for that. But the basic principles of how they work, everybody needs to understand. And again, when I show this picture, everybody goes to sleep. They don't want to think about the physics of electricity, but it's really not that difficult. And for us, there are really two things to understand: monopolar circuits and bipolar circuits. Monopolar is most of what we do: polypectomy, sphincterotomy, and so on. This is where you need a return plate to take the electricity back to the generator, and the tool is something that you're very familiar with, like a sphincterotome or a needle knife or a snare. Bipolar circuits we use less frequently, but we do use them during ERCP. This is where you don't need a return plate because the circuit is contained within the device. It goes back to the generator. And for us in ERCP, we're really talking about lithotripsy. The electrohydraulic lithotripter is a bipolar system, and so there is the bipolar RFA probe. I am not going to say anything more about accessories because there are so many of them. But again, I would stress that you don't need 10 different sphincterotomes. You maybe need 2. So standardize your equipment, get used to using them, get good with them. Don't use 10 different devices that look the same but do things slightly differently because you'll never get good at using one particular one. Guide wires have become absolutely fundamental to what we do. So understand what they can do, how they're made, what they're made of, and how long they are. Plus, and they're very complicated. Guide wires don't look like anything much, but they're actually very complicated internally. And one thing you have to understand is the size. And why we've ended up with this terrible system, I don't know. We used thousandths of an inch, millimeters, and French gauge. And you have to understand how to convert one to the other because different things are called different by different standards. Length is easier and tip diameter is easier. But if you have something that's 025 or 035 is the standard guide wire, thanks to our radiology colleagues a long time ago, stands for 35 thousandths of an inch, but it's just under 1 millimeter in diameter, and that's 2.7 French. Not easy. But this is a 3-to-1 difference, so that's not too difficult. But unfortunately, you have to learn that. You will hopefully get to use the mini scope inside your duodenoscope. And that's the spyglass imaging system that really is very, very helpful to us. It allows us to do many things, such as electrohydraulic lithotripsy. I'm sorry. Electrohydraulic lithotripsy for breaking up stones. And if you have a laser, you can use it for laser lithotripsy for stones too. Both of these really should be done under direct vision with a cholangioscope to make them safe. But again, that's become part of our standard armamentarium for dealing with stones. Stents, you will come across many, many stents. Just remember it is somebody's name. Charles Robert Stent was a dentist who invented something quite different, but his name became attached to what we call stents today. And this guy, Hans Wollsten, working in Switzerland, he changed his name to Wollstent and developed the first expandable stents that we now use, of course, made of different materials. They can do so many different things for us, which you will learn about, again, have become fundamental to ERCP. Here's just an example of a patient with a malignancy in the pancreas that required stenting, both bile duct and pancreas, a metal stent in the bile duct and a plastic stent in the pancreas. And we also, of course, use stents for malignant biliary obstruction, short-term, sometimes long-term. We've also used stents, this is not strictly pancreatic or biliary, but stents within the duodenum to relieve malignant gastric outlet obstruction are also of the same general design, although much larger, and can be used to treat the gastric outlet obstruction first and then give us access to the bile duct using EUS. So here, endoscopy, ERCP, EUS have been combined to solve the problem. And here's that thing I mentioned earlier. This is an hepatogastrostomy, where we couldn't get access to the bile duct from the papilla. So the obstruction was relieved by placing a stent directly into the left hepatic system from the stomach. And this is a hepatogastrostomy. A whole new breed of stents has become available in the last few years, and this is the lumen opposing stent that was designed for treating pancreatic fluid collections. It's become very, very useful to us. Again, different designs, different manufacturers, but you will see these used also very expensive. So finally, let me make some comments about training. The way we train people hasn't really changed a whole lot. Of course, we do a lot of didactic things like this, like you're going to experience over the next 40 weeks or so. But one-on-one training or two-on-one training as an apprentice is still one of the main ways that we teach people. You learn by watching, you learn by doing, but it's very hard to quantify. You know, how much do you need of which? How do you measure things? Nobody's really solved this, but there are a number of useful publications that make you understand what's happening. So this is a study from Vancouver, published 5 years ago, trying to ask the question, or answer the question, when do trainees reach competence? In other words, how much do you need to do to be good? So this was looking at all the studies that were available in the literature at the time. There were only 9, 137 trainees, 17,000 ERCPs. So this is what they found, that cannulation competency, however it was measured, was achieved in anything from 70 to 400 cases. 2 studies looked at pancreatic cannulation, was achieved in 70 to 160 cases. That's usually a little easier than biliary. 5 studies looked at selective cannulation. That means getting the duct you really want. That occurred anything from 79 to 300 cases, and 4 studies looked at biliary cannulation alone. And again, you can see it's variable between 160 and 400 cases. Patients who had a papilla that had never been touched by anybody before, only 1 study looked at this, and again, they thought it was 350 to 400 cases. So you can ask in your center or place where you trained or you're about to train, do we achieve these thresholds? I can't answer that for you. You're going to have to figure that out for yourself. But I know in our unit, our advanced fellow gets in excess of usually in excess of 600 cases a year. So at least they're being exposed to enough cases. They should become competent in the cannulation area. This is an interesting study from Romania. They looked at all the RCPs in their 2014 training program, over 500 cases, 500 procedures, I should say. They compared one expert with 3 trainees, and it's interesting. These trainees look pretty good, but they were being supervised, of course, which means that the supervisor can step in if they're not succeeding. Good success rate for cannulation, overall success rate pretty good. Post-ERCP pancreatitis, no difference. Overall adverse event rate, no difference. Mortality, no difference. So the conclusion was that the caseload certainly improved success, as you would expect, but there was no particular effect on adverse event rate. The complication rate didn't change. And I suspect that's because the supervisors didn't allow it to. They stepped in when they had to. Here's a multi-center study from the US, just published 4 years ago, looking at 5 advanced endoscopy fellows assessed over a 12-month period. They started after they'd done 25 cases, so they started with their 26th case, and each case was scored, and they used this interesting system called the Q-sum analysis. You score each case, and that's additive over time, so as you get better, the curve goes up. So that truly is the learning curve. And they looked at over 1,000 cases, a mean of 200, 80% were biliary. And what you find is sort of what you'd expect, that each person is not the same. There was substantial variability in skill levels and the ability to learn. But fortunately, everybody achieved competence in cannulation by the end of that 12 months. So everybody can be taught. It's like driving a car. Everybody could learn to drive, but there are some drive better than others. So there didn't seem to be a magic number of cases to achieve competence. I think, as you saw from a previous publication, there's a whole range from anything from 70 to 400. And I think that's my own experience too. So one last comment about training. What happens to the outcome of the procedure and the risk of the procedure if a trainee is involved? In other words, you get worse outcomes if a trainee is involved. That's always a suspicion. And here's a study looking at, this is an international multi-center study published last year, 1,800 ERCPs, 21 trainees, 16 experts, 16 supervisors. And you can see that the overall success rate was the same. The complication rate was the same. The serious adverse event rate was actually worse in the non-trainee cases. That's sort of expected. So trainee involvement in a teaching situation is safe, does not compromise the success of the procedure. So finally, a couple of comments. So I think this is what I've learned over these 40-something years of ERCP, that the majority of diagnostic problems can be solved by non-invasive imaging, because now it's so good, CT and MR, and EUS when necessary. Most benign diseases, if not all, can be solved without surgery. The majority of inoperable malignant diseases can be palliated non-surgically by us. Surgery with chemoradiation is the mainstay of cure, the few patients that we can. Advances must be based on clinical trials. There's no point in just saying, yes, I think this is better. You've got to prove it by an appropriate trial. And there's no question that multidisciplinary management is essential. It's easy for us to say that because we work in a referral center, difficult in the community, but you have to have input from every form, every specialty to make decisions. And this is what's happened in our world. You know, we have a spectrum now from open surgery of the past and still today when necessary, all the way down to intraluminal alone with interaction in the middle. And of course, the trend has been towards less and less invasive procedures to cure our patients, and we're part of that. And if you want to read more, you can always buy our textbook. I'm not sure it's available in Pakistan, but hopefully it is. It's because that summarizes nearly all of the things that I've been talking about. And I'll stop there. Thank you.
Thank you, David. Thank you for a very elaborate lecture and very important lecture, because you were the opener and you have set the stage for the upcoming webinars. That's been a wonderful session. I'm sure the participants must have appreciated a lot. There have been few questions which I've answered while you are delivering the lecture. But the kind of presentation that you gave, I think it has satisfied all the participants. Sir, do you want to say something?
Thank you, David. As expected, you have taken us from the very beginning of understanding the anatomy to really where we are today, which is a real shift, especially in the last 2 decades. There's been major changes, advances. And just to share a couple of anecdotes quickly, I remember when I went to a course, and it was one of your colleagues, Adrian Hatfield in London. And I just asked, as an innocent trainee at that time, why do we need to do a pancreatogram when we know that we only want to look at the stone? And he says, he asked me, he says, do you know what ERCP stands for? It stands for cholangio and pancreatogram both. And those were early days, very early 90s. And then came the MRCP, and obviously things change. And the one thing that you mentioned today, where we struggle here, because the risk of cholangitis, because of the reuse of accessories, and not as adequate cleaning of the scopes as you see in the developed world. I think the point that you made about using the wire, getting deep into the intrahepatic system, and then injecting and viewing the system has obviously changed a lot, because you don't have that issue of, if you follow that, you don't have that issue of injecting and not being able to drain the system. So draining, obviously, and with the new wires and the new accessories, things have completely changed. And obviously I remember I've done a few cases with fiber optic, and it is, those who still have necks and use fiber optics, they're lucky. But I'm sure, we have had a very good session, and a lot of learning and revision of a lot of things, and a lot of new things as well, David, which is what we expected from someone like you. So thank you very much.
Thank you.
There are a couple of questions, Gyas.
Sure.
I know there are comments. So people are obviously very appreciative already, but there are no questions here. Generally, David, I think you would agree. I would like to just ask you one question. Here, a lot of centers, a lot of cities are actually embarking on this journey. They're just starting. So they should have at least adequate ERCP equipment, which means proper cleaning facility, proper scope, and at least basic accessories. You don't need all the wires and all the sphincterotomes, but you do need to have and understand those before you actually start ERCPs. So someone who's starting, what would you say would be the basic thing? I know you're not used to that, but having said that, well, this is what we do.
We started once upon a time, we started from nothing too. And at that time, of course, there wasn't much choice for equipment. But today you're faced with a huge array of scopes and accessories available to you. You just have to have the money to pay for it. But the serious answer to your question is you have to have space, right? You have to have an adequate room. It should be lead lined, although if you look at the modern fluoroscopy equipment, it really is pretty good. And we have one of the rooms where we use our C-arm is not lead lined anymore because the fall off of radiation away from the machine is so good. So it is possible to set this up in almost any space, which is much more helpful, but you do need space. You need an appropriate table. You need an X-ray table. Remember that the C-arms and equivalent that we use today, the X-ray source is under the table. Do not get a machine where the source is over the patient. They are very dangerous. The scatter is very high. You will become irradiated much more quickly than you need to be. So under the table source is the important type of machine. And modern C-arms really are very good. The digital C-arm is of high quality these days and can be used for ERCP. So that wasn't the case at the beginning, but it is now. So that's also much more flexible and they're cheaper. modern C-arms in the States, I think, compared to a fixed machine like our expensive ones, which could cost $500,000, the C-arms can be 100,000. So they're a fifth of the cost, which makes them a little bit more affordable. Make sure you have space for the fluoroscopy, because it's not just the endoscopy table, it's the fluoroscopy machine. Make sure you have a proper setup to run it. Make sure you have a way of storing images and reviewing images. Make sure it's high quality. If you have bad quality fluoroscopy, like when we go to the operating room, we still hate doing that because the image quality is never quite as good. You're in trouble because it takes you longer. Sometimes you can't see what you want to see. So a fundamental thing, we're so used to having good quality images with our endoscopes, you forget that the good quality fluoroscopic image is also important. Make sure the room is set up where you can look at both images, endo and fluoro, next to each other, one above the other, or side by side, like I showed you in some of the pictures. That's also important because if you're looking from two different parts of the room, one behind you, one in front of you, it doesn't work. That's not efficient or safe. So that's the room setup. I showed you the layout of the room that's ideal with the sedator, whoever it is, and your assistant next to you. Make sure that you have adequate room to move the patient in and out of the room. I know that sounds stupid, but sometimes the door is too narrow to get a bed or a stretcher in it, and you can't even start. So it's simple things like ergonomics, how you get the patient in and out, where you put them, how you transfer them, and the space that's required. So those are all the basic things that you need in the room. And then you're quite right to bring up the whole cleaning idea. Yes, there are very sophisticated and expensive ways of reprocessing endoscopes, but there are also some very simple ways too that are relatively cheap. It's still done right. You still have to follow a very strict protocol. Otherwise, you will transmit infection with the scope itself to the next patient, and that's, of course, you don't want to do that. And that's one of the reasons there have been a lot of publicity about this over the last few years. So make sure that that's close to the room that you're using. And then for accessories, you can make that very simple. You're quite right. You do not, as mentioned in my talk, you don't need 10 different sphincterotomes, maybe one. Get the one that's your supplier is giving you, as long as it works, and use it. Now, I know that's the whole question of reuse of single-use devices. That's a very difficult topic because we're not allowed to do that, but I know it happens. It's the real world. I used to do it a long time ago before it was the law changed. You'll have to do whatever you think is right. Some of those devices, they look simple to clean and they are not. So you run a risk of transmitting infection if you don't clean instruments or accessories adequately. There are still some reusable accessories available, I think, around the world. We don't have them anymore, but they are designed to be cleaned. And if so, then you have to clean them the right way. So there are lots of components to setting this up if you're doing it from scratch. It's not just an endoscopy room with a table in it. It's got to have a lot of other things, and you have to think out where to put things. Because if you get it wrong at the beginning, it's going to be with you forever, and you'll hate that. The best thing is to bring in somebody who's done it. They made all the mistakes, and you can learn from them. And I've done that many times in units around the place that said, look, how do we do this? What should we avoid? And each place has its own little quirks about shape of room, where they are situated, and so on. So you can benefit from other people's experience.
I can offer to the people who are watching, the smallest room that probably does ERCP would be our room in our setup. So if you want to see a very small room, then we have one with all the screens and everything, and we are performing significant numbers already. One point about the C-arm is that the orthopods and the surgical C-arms quite often are 6 inches. Whereas if you're ordering it for ERCP, then it's if you have the option, then it should be 9 inches, because then otherwise you're shifting it from one part of it.
That's correct. Yes.
There will be a couple of your friends who want to interact with you and thank you personally. Dr. Asif Tabas Naqvi is here. Professor
Yes.
Muhammad Khan.
I say him.
And then Professor Kafar.
Oh, hi.
Hi, Asif.
Hi, David.
Hi.
Would you believe I'm in Lahore now, not very far from where Gayas is. I'm just looking after this institution in private sector, which I may have told you before.
Yes,
but,
yes, I know.
and you know, it's a very hot summer here, and so wonderful to see you after some time. Wonderful. I just want to just ask one question about training, and you know, there are, in relation to use of simulators, particularly focusing on ERCP. What your views are on that? Because I didn't, I think, see you mentioning that, or maybe I missed it.
No, I deliberately didn't mention it because I don't think they're any good. We've played with simulators over the years. For some things, they can be pretty simple. So for you know, basic gastroscopy, of course, there are many models that we can use, mostly ex vivo and synthetic. Those can be simulated quite well using standard scopes. But ERCP is one of those things that's very difficult to simulate. It can be done. We've set up, there are a couple of companies in the States that have set up an ex vivo system, usually using a pig stomach and duodenum, and then they implant it. They actually take a chicken heart and fashion it into a papilla. It's quite clever, and implant it into the duodenum, so you can keep changing it, because once you cut it, it's gone. But you can sort of implant it into the duodenum in place of the papilla, because the pig really doesn't have much of a papilla. So you can try and recreate that. That's pretty good to give people the sense of what scope position you should be in and so on. So we have done that. There are some completely synthetic models that try to recreate ERCP. The computer simulations really were, I don't know that they exist anymore. They're too expensive and they're not as good. So if you're going to do anything, I would certainly use, well, the pig might be difficult in Pakistan, but you can use these ex vivo models at least to get people started, where to put the scope and so on. But you know, for most of us, it's we use patience still. Right? That hasn't changed.
Yeah. There are two questions, if I quickly can ask you, David. I know we've taken a lot of your time.
No, that's
one
fine.
is the trainees are asking about the position that you put your patients in. Are you using left lateral, supine, or prone? Any preferences, and why? And the second question that has come about is that what is a good time for a trainee to actually get into ERCP, and should everybody who's actually doing endoscopy actually get into ERCP? Is that what's happening in US, and how do you decide that?
Yeah, so I'll answer that second one first. So not everybody should be doing ERCP, and not everybody needs to be trained. So in the States now, there are specific advanced endoscopy fellowships, which is a 4th year. So after the 3-year standard GI fellowship, they can apply for a 4th year. And there are now, I forget how many around the country, something like 60, maybe more. But there are specific 4th year fellowships, and they usually offer ERCP and EUS, and then other things like ESD and stent placement and so on. So that's how it's done. Have I seen people who have gone through a standard fellowship for 3 years and then do ERCP later? Yes, it does happen. It's not very common because it's difficult to do, to train yourself, because most institutions now will want agreement that there has been a training program done by that individual, and because somebody has to sign off that they went through a training program. So that doesn't happen so much. So a specific year spent in advanced training is the common way to do that here in the States, and I think mostly in Europe too. But it's selective, and not everybody needs to do that. And ERCP and advanced procedures should be concentrated in certain centers so that they get a high volume and good experience. Doing an occasional ERCP is not the way to do it. That's where you get the complications. We learned that a long time ago. And the one thing that has happened in the US is that the occasional ERCPist really has gone. There are very few of those left. It's not lucrative financially. It's a lot of effort. Your success rate is low. So there's really no incentive to do it that way anymore. Most places have built a team, or certainly one person who does all the experience. In terms of the specific question of patient positioning, it's a very interesting topic. When I started ERCP, I followed the tradition at the time, which is that the patients were prone, and we sedated them. We hardly ever used general anesthesia. That was a long time ago. And then as time went by, we did a few patients supine, still under sedation, because sometimes the supine position actually is a little easier. And then when I moved to the States, everything's different because nearly everybody gets either heavy sedation or even general anesthesia with intubation. And for me, I like to make things good for everybody. So the anesthesiologist likes the patient supine because that's how they intubated them, and I keep them that way. So I now, the majority of our ERCPs that I do, patient is supine. We looked at our success rates between prone and supine, and it doesn't make any difference. So I think if you get used to it, it really doesn't matter, provided you can put the screens in the right place. And I made just a brief comment during the talk that if you can move the screens to wherever you want them, then the patient position really doesn't matter from that point of view. So but we now do them supine, but there are some situations where prone is actually a little easier. And if a patient's intubated, you can turn them over. It's a little bit awkward sometimes, but so you can do it either way. But I like to make the anesthesiologist happy. I have to work with them all day.
I'll go with you there. I think it's quite often them who decide what position they prefer, and as long as one is comfortable and you've got the screens rightly set, you should be able to do it in whichever position they
Yes.
Professor Altaf, do you want to say something?
No, just to thank you and Saad for starting this initiative, which is very useful for practicing gastroenterologists and trainees alike. And a wonderful talk, David. I thoroughly enjoyed it. Thank you very much.
Thank you.
Professor Uma, are you there?
Yes, Dr. Gyas. So can I say something?
Sure, sure.
Okay. So my heartfelt sort of appreciation to Dr. Gyas for starting this program. I think, and you have a right start with the right person. I think David is a global mentor. I always call him as a global mentor, that he is mentoring so many his students, even like me. And he has a great role of establishing, advanced GI centers and supporting them in this part of the world. I think it would be very unfair if I don't mention here that first time he came to Pakistan in 2006 on our request, and then he is such a regular visitor, and this show his great contribution. So you are, David, always a global teacher, and I think this thing has gone long way in Pakistan also, your role mentoring our center in Karachi and Lahore. And I'm very indebted to you for starting particularly our center from the very niche to the now advanced centers. And my always very warm welcomes to coming to Pakistan, inshallah, as the COVID is over. And my wishes for this great success to these programs. And once again, my congratulations to Dr. Gyas and his team. Thank you very much.
Thank you, Professor. Once again, from my side and from Saad Nia's side, big thanks to David Carlock for opening this webinar series. I'm really thankful to you for sparing time, and I wish you a safe journey from COVID. And I hope that we see you in Pakistan very soon. Shamsu, you want to give some message? But otherwise, I have a message for the next webinar, which is on next Sunday at 6 in the evening. And Dr. Mustafa Arai is going to speak on introduction to the EUS equipment and again, learning curves. So, Shamsu, do you want to say something? Otherwise,
well, sir, thank you so much for giving me opportunity. I am Shams Solanki and I am representing Wilson Pharmaceutical. That's a great and very informative session and great talk, great lecture by Dr. David. And I appreciate and I really wants to again continue these all sessions. Again, I must pay thanks to Dr. Ghayas and Dr. Saad and his team from Wilson Pharmaceutical platform as a corporate webinar sessions. Thank you so much for giving me opportunity to deliver such a great and informative sessions to all other gastroenterologists, newly gastroenterologists. So, sir, again, so nice of you, and thank you so much for your time and your informative session.
well, for the information for all this session is available on YouTube as well. So those who have missed the session, please let it know. let known to all that you can watch it on YouTube as well in your convenient time. So thanks to all, and bye-bye, and see you next Sunday. Take care.
Bye, sir. Bye. Thank you.
So much, sir.
Thank you.